Thank you for sparing your time to do this e-tutorial on diagnostic test accuracy studies. This has been developed by myself, Professor Yoav Ben Shlomo, and Dr. Penny Whiting from the School of Social and Community Medicine at the University of Bristol. We'd also like to thank Dr. Shane Clark, who developed the clinical vignette that we will use to illustrate some of the points we wish to make. Finally, this piece of work is part of a larger program grant that has been funded by the Medical Research Council. In the following e-tutorial, we'll discuss issues around diagnosis, in particular some of the measures used to allow us to evaluate which of several tests may be better or worse for reaching a diagnosis. We will also discuss some of the potential biases when reading publications around diagnostic test accuracy studies, and finally discuss how these results can be used to help improve patient management. Diagnosis is an obvious feature of any consultation, as patients presenting with new symptoms obviously wish to know what's causing their symptoms. Diagnosis is also critical in terms of determining the right treatment and in some cases reassuring patients that their condition is self-limiting and will go away by itself. And finally, with chronic conditions, it helps patients come to terms with their future prognosis. What is a diagnostic test? This sounds pretty self-obvious, though we tend to think of diagnostic tests as things that we order from the laboratory or maybe imaging procedures. In fact, a diagnostic test can include anything from a simple history or physical examination, as well as more invasive procedures. Why do we order tests? Well, usually to help us either rule in or rule out a diagnosis. However, we may order tests as part of a screening procedure, or sometimes to inform treatment decisions and provide information on prognosis. So, for example, a coronary angiogram will not only confirm the presence of atherosclerosis, but will also tell us what the heart function is like and therefore may alter our decision on what management we might do. Sometimes we order tests because we're following a specific protocol, or in the worst case scenario, it's easier to order the test and actually think about why we're doing it in the first place. Why do we need new tests? Well, we don't always need new tests, but if the existing test is either risky or fairly invasive, or painful or expensive, then clearly a new test may be superior for all of the following reasons. There are three stages in developing a new diagnostic test. The first stage, or development stage, simply shows that the test can differentiate patients with the target condition or disease from normal individuals. Assuming the test survives this stage, it will then go on to stage 2. The important distinction here is that rather than taking normal participants, one would take the clinical spectrum of patients one would expect to see either in outpatients or in inpatients, and then still see whether the test is superior than other existing tests. Finally, if the test still seems to be good, one would actually want to demonstrate that using the new test improves outcomes or is clinically effective compared to using the old test. How do we measure diagnostic accuracy? There are a whole variety of different measures that we will discuss in this tutorial. The important thing is, in each case, one compares the performance on the index test or new diagnostic test against some sort of reference standard, often used to be referred to as a gold standard. By having the data on both types of test, you can then cross-tabulate this information in what is known as a 2x2 table. From this, we can calculate a whole series of measures which are shown below, such as sensitivity, specificity, likelihood ratios, and so on. However, before we go into how you calculate this, let's discuss a clinical scenario. In this case, we have a 45-year-old man, let's call him Mr. Smith, who presents to his general practitioner with knee pain and malaise. He's had swelling of the same knee 3 years ago, but that resolved with injections of corticosteroids. The pain's becoming increasingly uncomfortable over the last 3 months, but there's no other evidence of other joints involved, and there is no significant past medical or family history. He drinks around 21 units of alcohol a week. On examination, there's a marked right knee infusion and some tenderness of some of the joints. Aspiration of the joint reveals no evidence of sepsis nor of crystal arthropathy. 2 weeks later, Mr. Smith reports stiffness in both shoulders and an infusion at both elbows. He is now significantly disabled by loss of arm function. Examinations of his hands and wrists is unremarkable. So, as the clinician seeing Mr. Smith, you suspect a possible diagnosis of rheumatoid arthritis, but are not sufficiently confident based on his clinical history and signs alone. However, a quick search of the literature using PubMed highlights a paper that might actually help you decide whether the use of anti-CCP antibodies will help you make an early diagnosis of rheumatoid arthritis. So you decide to look at this data. In this case, we have patients with rheumatic symptoms who've been given anti-CCP antibody, known as our index test, and in this case our reference standards is a clinical diagnosis, usually by a specialist such as a rheumatologist, using the ACR criteria, usually after a period of follow-up. In this case, we want to cross-classify the results of the anti-CCP test against the clinical reference standard in our 2x2 table. This is what a 2x2 table can look like, though there are other variations. In this case, we've plotted the reference standard here as the heading for the columns, and we have the left column showing the positive results and the right column showing the negative results. And in the rows, we have the index test. So in this case, we have index test positive in this row, and in this case, we have index test negative in this row. The letters inside this 2x2 table stand for true positive, false negative, and true negative. In other words, true positives are patients where the index test said they had rheumatoid arthritis, and this was confirmed by the reference standard. Similarly, true negatives are patients who the index test said were normal or did not have rheumatoid arthritis, and again confirmed by the gold standard. However, false positives are patients who the test suggested may have the condition of interest, yet the gold standard or reference standard did not. And similarly, false negatives are patients that the index test thought did not have the condition of interest, but the gold standard said they did. From these data, we can calculate two of the commonest measures, known as sensitivity and specificity. The definitions are shown in this slide, but just to make it clear, sensitivity is the proportion of patients with the condition of interest, in this case rheumatoid arthritis, who have a positive index test. Specificity, on the other hand, is the counter to that. Those are the proportion of patients who do not have the condition of interest, in this case rheumatoid arthritis, who have a negative index test. Thus, a test with high sensitivity will have a relatively low risk of getting false negative results. Similarly, a test with high specificity will have a low chance of getting false positive results. If we go back to our 2x2 table, you can now see how we could calculate these values. So in the case of sensitivity, we have true positive divided by true positive plus false negative, or the left-hand column total. And similarly, specificity, we have true negative divided by true negative plus false positive, or the right-hand column total. Just have a look at the table for a minute to think about how you do the calculation. So this is what we get. For sensitivity, we get 54%, while for specificity, we get 96%. Either of these values could lie on a range between 0 to 100, where 100 is the best you could possibly get. So clearly, we have moderately good sensitivity, but nothing too impressive, whilst we have pretty high specificity. How does that help us with our patient? Well, whilst sensitivity and specificity are very good technical features of the test, and allow us to compare one test with another, they don't actually help us that much, because of course sensitivity and specificity can be calculated once we actually know whether the patient does or does not have rheumatoid arthritis. But in this case, when we first see the patient, we don't actually know yet what the diagnosis is. What we actually want to know is what is the probability, given the index test result, that the patient will go on and either be proven to have rheumatoid arthritis or not. We'll come on to how we calculate this in a minute. Two useful acronyms that were developed by David Sackett to help remember which way round sensitivity and specificity go are known as SPIN and SNOUT. SPIN standing for high specificity, positive result good for ruling in a disease, and SNOUT standing for high sensitivity, negative result good for ruling out. So from our calculations, we've seen that anti-CCP has a very high specificity at 96%, whereas its sensitivity isn't very good at 54%. If we were just guessing by tossing a coin, we'd expect to get the right answer half the time, or 50% of the time. So in this case, what type of test result would be more helpful in reaching a diagnosis? Of course, the answer is a positive test result, because that's really helpful in ruling in the diagnosis of rheumatoid arthritis. In this case, only 4% of patients who are positive would turn out not to have rheumatoid arthritis, in other words, false positives. However, a negative result would not be very helpful, and we wouldn't wish to exclude the diagnosis, because in this case, 46% of patients with rheumatoid arthritis would still have a negative result. Now, anti-CCP is a laboratory-based assay where we get a continuous measure of activity, and so therefore clinically we have to decide what value we take to choose as our cut point for being abnormal or normal. As you can see from the picture, this is really a sort of seesaw effect. If we choose a very high threshold for saying something's abnormal, we'll get a very specific test, i.e. few false positives, but unfortunately we'll end up missing quite a lot of cases with milder degrees of abnormality who won't reach the cut point. If on the other hand we decide to be more liberal and take a lower cut point, then of course we'll enhance our sensitivity, but at the cost of specificity. So the actual decision of what level to take is really based on a clinical factor about weighing up pros and cons of either missing cases or wrongly ascribing cases to people who don't have the disease. Okay, there are two other values though we can also calculate from exactly the same data, and these are known as the predictive values. We have both positive predictive values and negative predictive values. So in this case, if you have a positive test, the positive predictive value would say is what is the risk or probability of someone with a positive test actually having the disease of interest, and vice versa. If you have a negative test, what is the probability of someone with a negative test not having the disease? These are very helpful calculations and actually are more relevant from both a clinician and patient perspective, but there is one major limitation in their interpretation, and this is because the actual values you calculate are dependent on the prevalence or how common the disease is within your population. In the context of a research project, this may be totally artificial because the researchers can select how many cases and non-cases they wish to test on, and often this will be done on a 1-to-1 ratio. So for every case they may select one non-case, and this may totally not reflect the reality of your clinical practice. So for example, in a clinical outpatient setting where the referral process of selection will mean that you're much more likely to have more cases, your prevalence will be higher, and therefore your positive predictive value will also go up, in comparison, say, to patients seen in primary care, where there will be far more false positives and your positive predictive value will go down. Therefore, the important thing to remember is the values you calculate are totally dependent on the context or the patient population from which they were tested on. So in terms of how we do the calculation, this is very straightforward. The positive predictive value, or PPV in this abbreviation, is simply the number of true positives, those people whose tests suggested they had the disease and we confirmed that, divided by all the true positives and the false positives, all the people who had a positive test. Similarly, the negative predictive value, or the number of true negatives as shown in this square, divided by all the true negatives but also the false negatives, all the people with a negative test. And finally, we can calculate the actual prevalence of disease in our population. That's the numbers here in this column, both the true positives and false negatives, divided by all the participants in the study. In other words, all 4 cells. So if you have a look at this side of the slide, we've got the numbers from our research study. Write down on a piece of paper what you think would be the numbers to calculate the positive predictive value, negative predictive value, and the prevalence of rheumatoid arthritis. So as you can see, the positive predictive value is 82 divided by 82 plus 13, which is 95. Similarly, the negative predictive value is 301 divided by 301 plus 71, which comes to 372. And the prevalence is 82 plus 71, which is 153, divided by all the number of observations, that comes out to be 467. So if you then do the calculations, we get a PPV of 86%, an NPV of 81%, and a prevalence of 33%. So where do we go from this? Well, you might at first think that because the PPV and NPV are fairly similar in magnitude, 86% and 81%, they're both equally good. But in fact, that would be misleading. What you have to remember is in this study, the prevalence of the disease was 33%. So before we knew the results of the test, we could have said, by chance, 1 in 3 patients would have rheumatoid arthritis. So here you can see that if the test comes back as positive, our probability has shifted from 33% to 86%. So it's moved quite a long way to making us feeling fairly sure that this patient might have rheumatoid arthritis. On the other hand, if the test came back negative, we've simply shifted from 33% to 19%. So we have gained additional information, but we're still not that sure whether they really don't have rheumatoid arthritis. So as you can see, the sensitivity and specificity, the results for sensitivity and specificity are similar to PPV and NPV. And ultimately, we can only apply these results to our patients if we think the prevalence in our population is similar to that in the study that we're reading about. So what we've worked out is in this scenario where the prevalence of disease is around a third, 33%, on average, someone with a positive test will have an 86% probability of having rheumatoid arthritis, whilst if they have a negative anti-CCP test, they'll have an 81% chance of not having rheumatoid arthritis, or if you put it the other way around, a 19% chance that they still have rheumatoid arthritis. You might think that both the negative and positive predictive value are very similar, so they're both equally good, but what you need to remember is before we did the test at all, at a population level, our pre-test probability was a third. So you can see here that having a positive test shifts from 33 to 86%. It does in a negative direction from 33 to 19%. And that actually supports the same conclusions we got when we looked at the relative strength of the specificity, which was stronger than the sensitivity. Now, your problem is you want to use these results for your patient, Mr. Smith. Now, if Mr. Smith is an average patient and you think that his probability of having rheumatoid arthritis based on the clinical history and examination is 33%, then that's really useful because you can now tell him what you think the probability is after the test results back in. However, Mr. Smith may not be a typical patient, and your own clinical feeling about their probability of disease, what we call the individual level pre-test probability, may be higher or lower, in which case these results may be misleading, and we'll go on and show you how you could use these results in a much more useful way, literally customized to the individual patient that you're seeing. This leads us to a new concept and a new calculation called likelihood ratio. The definition of a likelihood ratio is it's the number of times more likely a test result is to be expected in a person with compared to without the disease. And what it's really good is it gives you a simple single measure, which as you'll see in a minute combines sensitivity and specificity, to tell you whether you can rule out or rule in a condition. Technically, there are several different ways of doing this. You can use a formula, you can use what we're going to show you in a minute called Fagan's nomogram, or nowadays with computers and apps, you're much more likely to use a simple online calculator. And we've given you a link to one here if you're interested, and we'll demonstrate it in a little while. But there are other sources available on the internet. Okay, so let's just go through the technical aspects of how you calculate these things. So here now we're really interested in the columns of our 2x2 table. So a positive likelihood ratio, LR plus, is simply the sensitivity, which we calculate from this column, divided by 1 minus the specificity from this column. Of course, if you remember, 1 minus the specificity is the same thing as the false positive rate. So if we use the data on the right-hand side, in this case, if you remember, our sensitivity was 54% or 0.54, and we divide that by 1 minus the specificity, which was 0.96, or if you turn that around, 0.04. So we get 0.54 divided by 0.04, and we get this value of 13.5. Similarly, for a negative likelihood ratio, we take 1 minus the sensitivity, which is exactly the same thing as the false negative rate, and we divide that by the specificity. And again, if we use the numbers we've already calculated, that's 1 minus 0.54, or 0.46, divided by 0.96, which comes to 0.48. Now, you might be wondering what do these numbers actually mean, and I find it useful to explain it by saying, let's say we simply guessed
the diagnosis of the patient that came into the room in our consultation by tossing a coin. So if we did that with hundreds or thousands of patients, on average, for patients with the disease, we'd get the right diagnosis half the time, or 50%. And similarly, for patients without the disease, we'd also get that right half the time, or 50%. Now, in this case, our sensitivity of guessing would be 0.5, and our specificity of guessing would also be 0.5. So as you can see, the negative and positive likelihood ratios would simply be 0.5 divided by 0.5, which comes to 1. So the useful thing to remember here is the value of 1, or the null value, is the equivalent of simply guessing. In other words, if the test result is close to 1 for both positive and negative likelihood ratios, you're simply saying that the test actually is pretty lousy, or is actually no better than simply tossing a coin. In other words, we might as well ignore the results. Okay, so here's, in this table, we just illustrate some likelihood ratios, both positive and negative, for different sorts of tests that we can use, both history and investigation. So for example, this is rather arbitrary, but in general, people define LR values of greater than 10 as being very useful because they strongly increase the probability. So in this case, for example, a patient who presents with a typical history of angina would have a positive likelihood ratio of 115. So they are very likely, if you then investigate them further through angiography, to have the disease. Similarly, if you want to pick up whether someone suffers from alcohol dependency and they score 3+ or more on the CAGE questionnaire, that has a very large likelihood ratio value of 250. On the other hand, if you do a renal ultrasound in case someone may have hydronephrosis and that's negative, that has a very small negative likelihood ratio, 0.02, so you have very strong evidence to rule out the diagnosis, and you wouldn't necessarily want to do any further investigations. And as you can see, I won't go through each one of these examples, but these values vary as you might expect. So some tests are much better at ruling in, some tests are better at ruling out. Okay, so what do we do with these numbers, or how can they help us interpret the risk of the patient in front of us rather than the average patient? So let's say in the scenario we presented of Mr. Smith that clinically, based on the history and your experience, you actually think that the risk of Mr. Smith having rheumatoid arthritis is not 33%, but actually slightly higher at 45%. Okay? Based on these likelihood ratio numbers, we'll be able to show you in a minute that if the test comes back as positive, you now would know that the probability of Mr. Smith, not the average patient, of having rheumatoid arthritis is now as much as 92%, whilst on the other hand, if it came back as negative, he would still have a 28% or almost 1 in 5 chance of still having rheumatoid arthritis, despite the negative test result. Okay, so now obviously how you interpret that is up to you, but I would argue that a positive test may be sufficiently strong now to rule in the diagnosis, and you may wish to manage Mr. Smith as if they had rheumatoid arthritis. On the other hand, a negative test probably would not convince you for sure that Mr. Smith doesn't have rheumatoid arthritis, and you may wish to pursue further tests or simply observe Mr. Smith to see how the natural history of his disease progresses. How do we use these numbers to calculate the post-test probability? Well, we have to thank the Reverend Thomas Bayes, who was an 18th century minister, who came up with some very nice algebra mathematics, which is often referred to as Bayes' theorem. And we're not going to bore you with the actual numbers or the algebra, but in very simple terms, what Bayes showed was that if you start off with a pre-test probability, something between 0 to 100, 0 being they definitely haven't got the disease, 100 being they definitely have the disease, you can convert that number into what's known as an odds, similar to what the bookies give you when you bet on the horses. If you then know the likelihood ratios, both positive and negative, you can multiply the odds to get a post-test odds, and then you can back transform that into what's known as the post-test probability. That's the thing that clinically we want to know, because that's the thing that we can explain to our patients. Now, you can do this actually very simply from this little diagram. This is known as a Fagan nomogram, actually published by Fagan back in 1975, where on the left-hand column, as you can see, we have what we call our pre-test probability. In the middle, we have a scale which reflects our likelihood ratio. You can do both negative and positive. And by combining the crosses on these different points, we can simply draw a straight line. And then finally, the bit we're really interested in is we can then read off our post-test probability. So in the case of Mr. Smith, if we believe he has a 45% chance of having rheumatoid arthritis before the anti-CCP results back in, we'd simply put a cross here at the 0.45 as shown by the mouse arrow. Similarly, this is a little bit tricky because the scale's quite fine. We'd have to put a little cross somewhere between the 10 and 20 to reflect the positive likelihood ratio of 13.5, or similarly 0.48 for the negative likelihood ratio. And then by going across, we can now read what we think are the post-test probabilities. So as you can see, if the test comes back as positive, Mr. Smith will have roughly a 92% chance of having rheumatoid arthritis, whilst if it comes back as negative, that's probably around about 0.25 or 25%. That's pretty easy to do, but much easier if you have access to a computer is, as I said, simply go to an online calculator. And in this case, these will have empty boxes, so you simply enter the number, what you think is the prior chance or pre-test probability in our jargon, 45%. You enter the likelihood ratio from the paper that you've read or from where you've already synthesized the evidence, in this case 13.5%, and you simply click the green button and up will pop up the result. As you can see, 91.6% for a positive test, or similarly for a negative test, 28.1%. And literally, you could do that in a few seconds, particularly if you had it as an app on your smartphone. Okay, so that was Mr. Smith. What about a new patient who presents to you in clinic who this time has a less convincing history or less convincing signs on examination, and clinically you think they're much less likely to have rheumatoid arthritis? So if I forced you to quantify that risk, let's say you came down with a 10% risk. So now on the pretest probability column, we'd put a little x by the 0.1 mark, and again we'd put an x for our positive likelihood ratio and negative, read across, and now you can see that if they have a positive test, their probability has gone up, but it's only gone up to 60%. So you may not be that convinced they have rheumatoid arthritis. On the other hand, if they have a negative test, their chance of having rheumatoid arthritis is 5%, or in other words, only 1 in 20 of these patients would actually have rheumatoid arthritis, which may be sufficient to convince you to treat them as if they do not have the disease. Hopefully by now you're feeling fairly confident in understanding some of the key concepts behind diagnostic test accuracy studies. However, you can't always trust everything published in journals. As you will see, there are several major types of biases that can distort the results calculated in publications, often making the test appear better than it will be in reality. These biases can be classified as patient selection bias, index test interpretation bias, reference standard interpretation bias, and patient flow and timing bias. And in the next few slides, we'll go through each of these in turn and illustrate the problems. Patient selection bias really reflects how the researchers recruited the subjects that took part in the study. Common problems are using a case control design or a selection of patients rather than taking consecutive or randomly selected patients. In an ideal diagnostic test accuracy study, we would really undertake a diagnostic cohort study. So for the example of rheumatoid arthritis, we would take all patients or consecutive patients presenting either in primary care or clinic with rheumatic symptoms. All of these patients would then undergo the index test, in this case anti-CCP2 antibody test. They would then be seen by a clinician using the American College of Rheumatology criteria, who was not aware of the index test results, who would then classify them into whether they thought they had the disease or not, that being known as the reference standard or gold standard. And then once we have the results of that, we can cross-classify the results from the index test against the reference standard, giving us our usual 2x2 table that we've shown you in the past. If you deviate from this study design, you can unfortunately produce biased results. So for example, a case control study would get a rheumatologist selecting some of his or her patients who they already know have rheumatoid arthritis, either because they've had the disease for many years or they're classical cases. And to compare them, they may often select healthy controls, either medical students or other patients from hospital who have no rheumatic symptoms at all. In this case, they use the anti-CCP test in both groups, but as you will see in a minute, this will generally produce overly optimistic estimates of both sensitivity and specificity. This can be illustrated quite nicely with the following two pictures. So in this case, you can see we have two groups. We have patients with disease, as shown by the pink area of the curve, and patients without the disease. And we're looking at a test, say anti-CCP, that is normally distributed. Now, depending on where we put our threshold for being test positive, in this case, drawn by the vertical line, you will see that the majority of patients with the disease are correctly picked up as being test positive, but there will be a group of people who we call false negative. That's the pink area that falls below the threshold. And similarly, amongst our patients without the disease, there will be some patients whose values are sufficiently high to exceed the threshold. Those are our false positives. Now, particularly if we select other patients with rheumatic symptoms, not with rheumatoid arthritis per se, but perhaps with other inflammatory conditions that may cause an elevation in anti-CCP. If, on the other hand, so let's say we set up a diagnostic cohort study where we select people who all have symptoms of potentially rheumatoid arthritis, but we don't know what their disease status is, and they may have other diseases or other inflammatory conditions that present with musculoskeletal symptoms. Now, in this case, having measured the anti-CCP levels, which we're going to assume are normally distributed, we will actually find there could be two distributions, as shown by the pink curve. That's amongst patients who turn out to have rheumatoid arthritis, and opposed to the white curve, which it turns out to be people who do not have rheumatoid arthritis. Okay, now we have to arbitrarily choose some sort of cut point to say whether the test is abnormal, as shown by the test threshold value here, the vertical dotted line. So in this case, as you can see, the majority of patients who turn out to have rheumatoid arthritis do in fact have values that exceed the test threshold, but there will be a group here, shown in this area, who are basically false negatives because their test value appears to be normal, but they tend to have the disease. Similarly, there will be another small group here, shown above the dotted line, who are false positives. So though they have symptoms of rheumatoid arthritis and they have levels above, it turns out later that they do not have rheumatoid arthritis. If, on the other hand, we set up our design so we actually select people on the basis that we know they have disease or they're healthy, what we would call a case control study, what we've effectively done is these two curves have been shifted further apart. So now when we draw the same test threshold, we appear to have 100% sensitivity and specificity because all of our cases are correctly picked up and none of our healthy volunteers appear to have an abnormal result. However, this is an artifact of the selection of our subjects who do not reflect what you would actually see in the real world in a clinical setting. So in this case, we will get overly optimistic results from our calculations. Okay, what about how the index test is actually administered? So here, just as in randomized controlled trials, we have the concept of blinding. By blinding, what we mean is that the interpretation of the index test must be done without knowledge of the reference standard, as obviously if you know the reference standard, that could influence your interpretation of the index test. Now, where the test is a laboratory assay, for example, anti-CCP, this isn't a problem because the machine has no knowledge of what the reference standard is. However, where it is more subjective, for example, an imaging test, say an MRI scan or a chest x-ray, if the clinician reporting that scan is aware of the reference standard, that may push them in borderline cases to report it as being positive or negative based on the results of the reference standard, and yet again, you will get an overly optimistic estimate of the index test. Similarly, there may be problems with the reporting of the reference standard, so you may have bias in how this is reported. Now, in general, our reference standard or gold standard will be something like post-mortem or tissue biopsy, or say, for example, for an infectious disease, it might be microbiology. Another issue around the gold standard or reference standard is we are assuming it is telling us the truth. In other words, it's 100% sensitive and specific. And therefore, if there are disagreements, our assumption is that the error lies in the index test and not in the reference standard. Now, in some cases, that may be acceptable, but in other cases, that itself may be a controversial interpretation. So, for example, in the case of early diagnosis of rheumatoid arthritis, the best available reference standard is the clinical application of the American College of Rheumatology criteria after a period of follow-up, yet it may be possible that some of those who are positive to the ACR criteria turn out, say at post-mortem, to not have had rheumatoid arthritis. So it's very important that the reference standard is interpreted blinded to the index test, And similarly, if there is a degree of subjectivity in the interpretation, one may actually choose to have several readers independently rating him and then getting a consensual view about that. So, for example, the ACR criteria, which are usually applied after some time, should not themselves include the anti-CCP results, as obviously that would introduce circularity in the interpretation of the anti-CCP results. What about flow and timing? So this is another important area. When we recruit patients for the index test, it is important in our 2x2 table that we try to account for all patients at the end of the study and that they also appear in all of the columns and rows. Now, that doesn't always happen, and there are a variety of reasons why that may occur. For example, some patients may have the index test, but if the reference standard does not occur for a period of time afterwards, they may either die before the reference standard is administered, or they may refuse to continue, or they may simply be lost to follow-up. Similarly, if the interpretation of the results are indeterminate or sometimes in an intermediate category, researchers may simply exclude them from their analysis, which can also be problematic, as we'll show in a minute. So it is important, for example, if someone has an indeterminate result either on the anti-CCP or the ACR criteria, they are actually shown in the flow of the patients. In this diagram we have what's known as a flow chart. So as you can see, we start off with 467 consecutive patients. In this case, all of them get the anti-CCP test, which is great. We don't exclude any. And as you can see, 95 come back as positive, 372 come back as negative. But when we look at the reference standard, you can see we have, in this case, 7 cases with an unclear diagnosis, and probably worse still on this side, we have 100 patients with an unclear diagnosis. Now, if we simply choose to ignore these patients and analyze the results, we could produce very biased results. So one possible solution is to do what's known as a sensitivity analysis, where you take a sort of best case, worst case scenario. So we could say, imagine all 7 of these patients did actually have rheumatoid arthritis or didn't, and recalculate the numbers, including reallocation of these patients as well. And that will give you both what you think is the worst case scenario, anti-CCP, or the best case scenario. The other problem that may sometimes occur, depending on the nature of the reference standard, is what's known as workup or verification bias. What we mean by this is that all patients receive the index test, but not all of them get the reference standard. The reason why that may occur are severalfold. Firstly, the reference standard may be very expensive, or it may be quite a risky or unpleasant procedure, and it may be that it's felt either unethical or patients simply don't wish to undergo the reference standard. So, for example, if the index test was something like an exercise ECG, but the reference standard was a coronary angiogram, patients may actually feel that if their index test is negative, they don't want to go through the invasiveness of the coronary angiography. The problem is, what do you do with these patients? So in some studies, what the researchers may do is actually classify those people, because they were index test negative, as truly not having the disease. Okay? Now, if they do that, they will be potentially missing some patients who turn out to be false negatives. And therefore, both their estimation of sensitivity and specificity are likely to be biased in the direction of making the test appear better than it really is. That's not ideal. What would be far better would be to either use a less invasive reference standard in those cases. So, for example, instead of an angiogram, using some sort of thallium scan or other procedure, or simply following up the patients for a longer period of time in the assumption that if they did actually have the disease and it was missed by the index test, this will appear on further follow-up. Occasionally, they just take a random sample of test negatives and do the reference standard on that group rather than all of the test negatives, to try and estimate what the false negative rate would be in the whole sample. So the important thing is, where possible, all patients should have both index and reference standards. Finally, there's often a gap or delay between when the index test was administered and then the reference standard. This may be helpful, for example, allowing further features of the disease to develop and therefore making it easier to apply the reference standard, but it could also be misleading or create more misclassification. For example, if patients recover, making it harder to retrospectively apply the reference standard, or for example in something like a UTI, whereby if the index test was taken from a urine sample and then the reference standard was taken from a different sample several weeks later, it is possible that a new UTI may have developed, and therefore the index test, which appeared to be wrong, was actually correct at the time of administration. Obviously, the length of time and the condition which you're studying will have to be considered on a case-by-case basis. In the case of rheumatoid arthritis, patients will often have treatment initiated which may alter the severity of symptoms, but hopefully will not alter other features, allowing you to correctly apply the reference standard. Finally, let's consider the generalizability of any published results to your patients. Let's assume that the study you've read has been well designed and well analysed, and you feel fairly confident that there are no major biases in the way the study's been undertaken. However, before you start to apply those results to your clinical patients or the individual patient in front of you, you still need to consider whether you can generalise the results of the published work to your population. In particular, things that you'd be interested in looking at will be variations in the demographics of the population or the clinical features, and also how the index test was actually done in the study compared to how it would be done within your setting. So though results may be unbiased, their applicability may not be ideal for your use. So here are a few problems with the example we've given you. Firstly, was the study conducted in primary care, or was it conducted within, say, a rheumatology outpatient practice? As we've already pointed out, the prevalence of rheumatoid arthritis will be very different in those two settings. Do the patients that the researchers enroll present with similar symptoms and similar duration to the individual patient that you're looking at? Are they of similar age? Have they gone through a similar pattern of previous testing? And also, for example, was the anti-CCP test reported in the paper the same as what your laboratory undertakes here? There have been future generations of anti-CCP tests, and the techniques used have also varied, as have the commercial manufacturers. So to conclude, diagnosis is without doubt an essential part of clinical practice, and in fact is the first thing we have to do before we can decide on the effective management or advise patients on their prognosis. There is no such thing as a perfect test, and every test we order, we should always bear in mind that we will occasionally get false positives and false negatives that may have serious consequences depending on the condition and the diagnosis. There are various different measures that can be very simply calculated either by hand with a calculator or nowadays with an online calculator, which can be derived either directly from the paper, from the 2x2 table, or sometimes, when the authors haven't always presented the details, can usually be worked out from the text of the paper. These measures include sensitivity, specificity, predictive value, and likelihood ratios, and we hope you agree that of all these different measures, it's actually the likelihood ratio that is the most clinical relevant measure and the one that is most likely to help you decide how to alter the management of your patient. However, before applying those results, it is important to consider whether the study has been well conducted or not, and if there are potential biases, what direction those biases may work on, so they may make the study results look better than they are in reality. Finally, you need to consider whether those results are applicable to your patient and whether the knowledge of those results will help improve the care of your patients, because ultimately that is the purpose of selecting the best diagnostic tests. We hope you found this module helpful and you've been able to follow it and understand it. Earlier on in this e-package, we asked you 5 questions to test your knowledge about diagnostic test accuracy studies and the concepts around them. Hopefully, since you've done this module, you'll have a greater understanding, unless you already were very familiar with all the concepts. We'd be very grateful, therefore, if you could now go back and continue with the web-based tutorial. Thank you for listening to this e-module.